Hi, I'm Drew Armstrong, Bloomberg's senior editor for healthcare. I'd like to welcome our panelists, Dr. Uché Blackstock, founder and CEO of Advancing Health Equity. I'll also note that Dr. Blackstock is a Yahoo News medical contributor, and Dr. Soumya Swaminathan, chief scientist from the World Health Organization. Doctors, welcome and thank you for being with us today.
Thank you.
So we're going to begin today talking about vaccine equity. We're in the middle of one of the biggest vaccine rollouts in history. And the conversation that I want to begin us with is, when we look at how the initial administration of vaccine and the distribution of vaccines have gone, has this been equitable at all in how things are being done? I look around at our data and I see richer countries putting themselves at the front of the line. And I suppose to a certain extent, that's a little bit unsurprising. But what are your thoughts about the considerations of equity among vaccines, both inside the US in terms of how communities are being reached, and then globally in terms of how we're seeing different countries in different parts of the world get access to vaccine?
Maybe I can start with a global perspective.
Please go ahead.
At the WHO. So at the WHO, as you know, we had this concern right from the beginning because this has happened in past diseases and pandemics and outbreaks. So we've seen this with HIV. It took 15 years before the antiretroviral medications that were available in the rich countries actually arrived in the African continent, which actually had the highest burden of HIV disease. During the H1N1 pandemic of 2009-10, we saw the same thing. We saw a few countries actually, purchasing and buying up all the available doses, both of drugs and vaccines, leaving very little for the rest of the world. And it was to avoid that we launched the ACT Accelerator in April of this year with the goals of helping to advance the R&D and development of as many vaccines and therapeutics and diagnostics as possible, but also to ensure equitable and fair allocation across countries and across populations. And so this was it is a unique experiment. I think it's probably the first time that we will be able to achieve a distribution in different parts of the world, more or less at the same time, give or take, a few weeks. And it's happened because of the coming together of many, many agencies, global health agencies, but also countries and foundations and philanthropies all supporting this initiative. So I think this time there has been a considered push to achieving equity. And the next few weeks and months will actually show how this is happening. Of course, right now we're in a position where vaccines are being rolled out in a couple of dozen countries, mostly high-income ones. And a lot of the low-income countries are still waiting for their doses. But what we're working towards as part of COVAX is to change that very quickly and start distributing vaccines in February, hopefully.
Dr. Blackstock, I want to turn to you. I mean, in the United States, we're in the first weeks of the vaccine rollout. Are we seeing equitable vaccine distribution? I know this was something that was planned for, but I'm curious for your perspective kind of in these early targeted days. And then I want to come back to both of you on kind of what is the right timeline on which to judge whether this is being implemented successfully.
I think, as you mentioned, equity was definitely planned for in the vaccine distribution process. We had the Advisory Committee for Immunization Practices who made recommendations regarding which priority groups should receive the vaccine based on those populations that are at highest risk, as well as those populations who are at highest risk for developing severe disease. And so we've had the rollout targeting healthcare workers and people in long-term care facilities, but we've also seen that the rollout has been quite chaotic and uncertain. And what I do see from this in these early days is that there isn't an infrastructure in place in terms of collecting data, and we can get more into this data about who is receiving the vaccine, on a granular level, down, racial and ethnic wise, but also accessibility of the vaccine. We don't really have any data on which areas geographically where what vaccines are available. And so that is data that is much needed that will help guide some of our efforts, and especially targeting equity.
So, a question for both of you: what's the kind of right time period on which to judge this? Because I think I work in the journalism world, and we obviously look at things. As soon as they're out of the gate, we're saying, okay, is this working well? Is it not working? But this vaccination campaign is going to be long, months and years we're talking about. So what is the kind of fair timeline on which to judge these efforts and begin to say, okay, this is being, they are doing a good job of this, or they're not? I know we're kind of at this very targeted stage where a lot of the focus is on healthcare workers and things like that. And so hopefully the demographics of vaccination look a lot like the healthcare workforce, though I know that there's some reasons why that's not been the case. But just addressing the time frame question, I mean, when is it proper and fair to make assessments of this?
I think that's a very good point, because at this point, at this moment in time, you feel a sense of, real anxiety and frustration, both by people and by their leaders, political leaders, when they see, the vaccines are already rolling out in some countries. But here we are, it's been a few weeks and we haven't seen any vaccines. And you can understand why they're anxious. The epidemic is raging and is out of control in many countries. But I think we do need to take a little bit of a longer term, medium or longer term view. And I would say a minimum of 6 months. First of all, it's unprecedented that several vaccines could have been developed within 12 months of a new pathogen, a new virus being discovered. And then secondly, for that to be scaled at the level of billions of doses, it is a huge ask. And I think the scientific community, as well as the companies, have really stepped up to the task. And we mustn't underappreciate or underestimate just the huge, humongous task of vaccinating billions of people. So I would say, maybe a year from now would be a good time to look back and then think about, how we fared in terms of equity across countries.
Dr. Blackstock, what's your view on that? Because I know we're certainly in the process right now of trying to collect demographic data, and we've seen issues of both vaccine refusal, and then I know some concerns about vaccine access in the United States, where I think some of these health disparities are kind of, writ small. We have a lot of the same problems that the rest of the world has, all within our borders.
Yeah, I think that we definitely need to be analyzing data in real time. I know we've already seen, even though the vaccines have only been out for a few weeks, we're already seeing disparities in terms of which racial and ethnic groups are receiving the vaccine here in the U.S. And I think knowing that data in real time and responding to it in real time has a lot of value to it. So while we may not see substantial changes, in weeks to months, I do think that we should be paying close attention to which populations are being vaccinated and who's able to access the vaccines.
Can I ask you, I mean, the data question, I run Bloomberg's vaccine tracker. I am arms deep in vaccine data all day, every day. I had a dream about our vaccine data collection spreadsheet the other night, which is not exactly what I thought my year would be like. But how are we doing on the vaccine data collection standpoint, just in terms of getting the information that public health authorities need to have to be able to make these decisions and make these assessments? What is that data environment like? Do we know who's getting vaccinated? Do we know how these campaigns are going? Are we even set up to collect this, either in the U.S. or globally? Dr. Blackstock, I know you've talked a little bit about this when we chatted earlier, so why don't you start with this, and then we'll turn to the global picture.
Sure. And so we know here in the U.S. that the Center for Disease Control actually has a reporting form that public health departments across the country should be using, with extensive amount of demographic data. So from zip code to gender to race and ethnicity. The problem is that, these jurisdictions are not necessarily required to fill in all of those boxes. And so what we're getting and what we're already seeing is incomplete data. So for example, right now, there are only 17 out of the 50 states that are actually reporting racial and ethnic demographic data. And so what we're seeing is incomplete data, and we're not really able to make decisions based on the incompleteness of the information that we do have. And so we need a more coordinated national response. We need public health departments to almost be mandated to submit those specific demographic data that will help drive, especially our equity strategy.
Dr. Swaminathan, is that the same case globally? I mean, how does the data environment compare in different countries that are collecting it? I feel like I almost see less demographic data showing up in some of the countries that are reporting on, at least on public-facing dashboards and things like that. What are you all seeing so far from the WHO's perspective?
Yeah, so we just heard about the challenges at the national level. And then when you get to the global level, obviously you depend on the data that's going to feed up, from the state to the federal level and then up to the global level. And at each level, you're going to lose, a little bit of detail and granularity. And these vaccine rollout programs have been started so quickly, with such urgency in order to save lives, that things are being improved and, they're evolving as we're going along. So I'm sure that it will improve, that we will start seeing, much more granular data. And for us, it's really important also, as Dr. Blackstone was saying, for us to look at the global level to see how different countries are doing in terms of their vaccine rollout, what problems they're facing. And we are already discussing with those countries that have started rolling out, to understand both on the operational and logistical side, but also on the demand side, the acceptance and what those challenges could be. So I think it's really important. And, you're doing a great job also of the vaccine data tracker. We hope that we will also have, the WHO will have by March, a dashboard that will be able to track vaccine coverage in countries. But again, we're going to have to depend on countries to actually provide that data to us in a timely manner.
Are there, you mentioned something I think is really interesting, the kind of supply, the demand side of this, where, right now we're in an environment where the supply of vaccines is not huge. Every dose does seem to be mostly getting used, obviously with some exceptions. But what are we seeing in early days around vaccine hesitancy or vaccine refusal? I know that has kind of certain characteristics in the US. I'm wondering about it globally as well. And how is that a problem we solve with this in the context of a pandemic?
So, so here in the US, we're seeing it based on just different demographic groups, even down to political affiliation. We're seeing vaccine acceptance, vary, racial and ethnic basis. And so I think that one area that needs to be focused on is public health messaging. We actually are months behind on expansive mass public health campaigns educating the public about the vaccine. And what I will say is, I don't think that campaign should be a one-size-fits-all. It really needs to target specific populations and the concerns in those populations, and should be culturally responsive and also done in a very digestible way. I will have to say that the amount of information that's out there on the vaccines, on the research and development process, can be overwhelming, even to myself as a physician. So we really have to find a way to communicate this information about what vaccines are, why are they important, not just to yourself, but to your community, in a way that is easily accessible to varying communities.
Dr. Swaminathan, how does this, globally, I think one of the things I thought was very interesting a few years ago when I was looking at measles vaccinations rate was seeing that in some places in Europe, it was actually quite a bit lower. We were writing stories about this in the United States, and we were actually looking at some of the data in Europe and seeing there was an even larger problem there in terms of measles cases. Can you talk a little bit about how this problem shows up in different types of global environments, both in the, outside the US and the developed and the developing world?
Mm-hmm. Yeah, so the first thing I would say is I think most of the surveys that have been done recently have shown that more people want to take the vaccine than those who don't want to. So there's still the majority of people who would like to take the vaccine. The proportion of those who are reluctant varies from country to country. And it is interesting that there are more people in the higher income countries in the so-called developed world that are hesitant to take vaccines in general, and in this vaccine as well, than there are in the developing world. And if you look at vaccine coverage, for example, you mentioned the big outbreaks of measles in Europe the last couple of years, as well as in certain parts of the US. Measles coverage in large parts of Africa and Asia has been going up every year, and measles outbreaks are coming down. Now, I just want to add to what Dr. Blackstone said. I think one of the things that people are concerned about is the speed with which these vaccines have been developed. As I mentioned, less than a year. The fact that all of the science has been playing out on the front pages of newspapers, and everyone doesn't necessarily understand, the technicalities of clinical trials. So I think a number of people, rather than being anti-vaccine, are just want more information. They want to be reassured, and they have questions that they want answered. So I think we need to do a couple of things. Governments will need to do a couple of things. I think the communication is absolutely critical before the vaccine even starts getting rolled out. We need to start communicating about how it was developed, how it's assured quality, how the follow-up is going to be done, and how the government is taking all steps to protect their communities, but also creating enabling environments for people. I mean, I think if you make vaccination difficult for the average person to access, then the turnout's going to be low. So trying to figure out what's the best way of actually doing vaccination in different communities and making it, convenient for them, and having someone who can answer their questions, and having credible leaders in the community, whether they are celebrities or whether they are spiritual and religious leaders or whether there are other kinds of community leaders. You need those kinds of things now to mobilize people, especially when we're wanting to vaccinate, over 70% of the population to basically bring an end to this pandemic. That's huge. You have to cover a lot of people. And I think the more communication we do, the better.
When you all both look at...
May I add something? No, I think Dr. Swaminathan brought up some really wonderful points. I wanted just to mention that some of the challenges that we're having in the States is that those communities that have been most devastated and impacted by the virus are the ones where we're seeing a higher degree of vaccine hesitancy. So that is, again, I think, points to the importance of not only communication, but the accessibility of the vaccine, ensuring that we don't just have it as we have here initially in hospitals and pharmacies, but we have mobile units that can vaccinate. We have in schools and community centers, that we really ensure that we make vaccines equitable to every community based on their needs.
I wanted to ask both of you, adding on to that a little bit. I mean, has the vaccine rollout in the U.S., as you all observe, where we've seen a handful of kind of changes of rules and a very, thoughtful but also highly complex system of kind of who goes first and how they go, does that, I guess what I'm trying to ask is some of that complexity in and of itself a problem when people don't really, the public may not understand, wait a second, when is it my chance to get this thing? Yeah, I thought I was going to be able to get it. I'm calling around. I can't find it. Okay, now the rules are changing, and then now they're going to change again. I mean, how problematic are these types of, either levels of complexity or kind of changes in how these things are done in terms of building trust, that people can go out and get this? You all mentioned making this easy, and it almost feels like what we're seeing right now is just the opposite of that in the United States.
Yeah, what I will say is I think, part of the issue that we had was that there was really been no national strategy to containing the virus. And so what we're seeing is we saw as a continuation of that in terms of the vaccine distribution process. But I will definitely say that public messaging is everything, and that any rapid changes without explaining why the changes and how they would benefit, communities and populations is really incredibly important, and that there has to be a high degree of transparency in the process. And I think people can understand why some of the earlier priority groups were given priority. But in terms of the later groups, there really needs to be, again, a public messaging campaign about why this next group is getting priority, and an explanation to the public. I think that will help. But also, I think that the public needs to understand that this is a quickly changing situation, and that depending on supplies and response, that there will be some changes that may be unexpected. But as long as we're communicating those changes in an effective way, that matters the most.
Are there lessons learned globally, yeah, from what we were seeing in the United States? Sorry to interrupt. Go ahead, though.
Now, I was just going to say that globally, we've made efforts over the last few months to really engage with, our constituency, which are the ministries of health of all our member states, and discuss with them the principles on which we're going to be basing this allocation. Because as you know, the COVAX facility is going to start receiving doses very soon. Now, these vaccines that we distribute obviously also need to have a regulatory approval. So we have the process of emergency use listing, we have the SAGE policy process, but underpinning what we call our fair allocation framework are the principles, the ethical principles based on which the prioritization was done. And there's a clear explanation for why some groups need to be prioritized. And this, of course, needs to be adapted by countries and contextualized. If you're talking about Africa, you're not talking about a lot of people above the age of 80 years. So when you talk about the elderly there, it's a little different population. It's people maybe with, comorbidities, HIV infection, and so on. So countries will adapt it. But they then need, in turn, to communicate with their population, their public, as to, who's being prioritized and why. And there needs to be a clear reasoning. And then, of course, then you have to, as you said, the operational and logistical mechanisms need to be put in place so that it's easy for someone to get the information and then to know exactly where they need to show up to get the vaccine and when. And I think, as I said, countries are developing these systems as they're rolling out vaccines just because of the urgency. And so I think over the next few weeks, we'll see some of these problems getting ironed out. And other countries that are watching are learning from those that went early and hopefully will avoid some of these mistakes.
From the WHO's perspective, I mean, have wealthier countries fulfilled their obligations here in terms of making vaccine accessible around the world? I look at, countries that have bought 2 and 3 times the amount of doses that they need to cover their populations. And I get why they're buying backups in case some of these things don't work. But then I also look at where COVAX is supplied currently, which I think is on average enough to cover somewhere around 5 to 10% of the population of the COVAX participant states. That seems like a huge disparity to me. Is that going to resolve over time? I mean, where are we in that? And do wealthier countries need to do much more than they have been doing here?
Absolutely. That needs to be resolved over time. And I must say that wealthier countries, they have pre-booked vaccines to cover their population several times over, but they have also contributed to COVAX. So they've made available funds. Many of them are now considering making available vaccine doses because, as they have excess doses, but we're sort of encouraging them to give us at the same time as they're vaccinating their population, not at the end when they've finished. So hopefully that will start happening. And we needed about $8 billion for 2020 and 2021. And, we've raised most of that fund. The COVAX facilities raised most of that. We will, though, need to continue beyond 21 because we're only going to get to about 20%, 25% maybe, if we're lucky, or 30% of the population of all of these countries. We have 190 countries as members of COVAX. So we will need to continue to fundraise and hopefully, we will depend on the donor countries to support the rollout in the lower income countries.
We have about a minute or two left, and I want to close on something that's a little bit different, and maybe Dr. Blackstock, you can take this first. We've been spending a lot of time talking about vaccine equality issues, but one of the things that we've been talking about internally is how prepared are governments and countries around the world for the kind of inevitable next pandemic, and what do we see in terms of pandemic preparedness inequality, disease surveillance, infectious disease surveillance inequality, and the kind of readiness for the next time we unfortunately will, I'm sure, confront this. I mean, what has this pandemic revealed about those shortfalls? Because it took us a year to get to having a vaccine, while we were having to deal with all of these other things in the meantime.
Right. So briefly, I think that what we've learned over this last year is what happens when we underinvest in our public health infrastructure, as was the case in this country, unfortunately. And so Obviously, we now know having a robust public health infrastructure will be key. Putting resources into pandemic preparedness will be key. And I also think looking at healthcare and how we deliver healthcare and who is insured and who isn't insured will also play a role of how we respond in the next pandemic. And so hopefully there are lessons learned that we'll be able to incorporate before the next one.
And maybe I can just add to those excellent points that it's clear that you need not just national, but regional and global plans, because you need to collaborate and act in solidarity when you're faced with a pandemic. One country doing it well and everyone else not coping is not going to help, as we've seen. The other thing is investments in science have paid off. The investments in science and technology, which developed all of these different vaccine platforms over the last few years, have enabled, the massive progress that we've been able to see in vaccine development. So I think investing in science and technology beforehand, building those capacities, having the global, regional, and national systems in place, and above all, when there's a pandemic, countries do need to come together. And I think the WHO is a very good place for countries to come together and work together to solve the problem.